Renu, how are you?
Good morning, Declan.
Good morning.
Is it good morning or good night? Or
it's very early.
It's very early. I remember the olden days when we used to set up the studio at Peter Mac at 5 o'clock in the morning.
Yeah, during COVID.
During COVID. There'd be no one there anyway, but at that time, there's definitely no one there. It's dark. But this is much nicer to come to the studio and turn on the lights.
It is because, well, I've been in here, it's 6 a.m. now, but I was in here at 4 a.m. Doing a podcast for the European Urology with Nikita Bat. So we've already recorded 2 segments for European Urology between 4 a.m. and 6 a.m. Looking, I'm off. I'm on holidays today.
So you can take a nap after this.
Exactly, but I was only getting warmed up because this podcast, of course, is going to be a cracker of a podcast. It's kind of it's bringing back by popular demand a really, really good podcast from last year. So last year we did an update on the EAU Prostate Cancer Guidelines. So that's what we're going to talk about today, the updated 2025 Prostate Cancer Guidelines. But last year we had Derya Tilki and Gianluca Giannarini, great friends of the podcast, on after the EAU to talk about the 2024 update. And that was one of the most popular podcasts of 2024.
And there were big changes in 2024 to update people on. So, we've brought the dynamic duo back.
We have. So let's go and welcome them here on the podcast. Our good friends, the urologists, Derya Tilki from the Martini-Klinik in Hamburg, who is the deputy chair, is it, Derya, of the EAU Prostate Cancer Guideline?
Yeah, the vice chair.
Vice chair, I got that right. And fellow guideline member Gianluca Giannarini joining us as well. And Gianluca, I think you're also on the dissemination committee of the EAU guidelines.
So I'm sitting in the board of the guidelines office, and I'm also chairing the dissemination committee. So
okay. Great. So that's part of the deal, isn't it? Getting the message out.
Yeah.
And of course, we love the EAU guidelines. Here in Australia, they are our official guidelines of our society, as they are in very many countries around the world. So this is the biggest global guideline. It's very different to AUA guideline and NCCN guidelines. They come out of the US, but this is a very big global guideline. So every year when it's updated, there's always a flurry of interest, isn't there? But it's a 250-page document.
Yeah.
So not everyone has time to go through it. There's a summary of changes at the start, but what we want to do today is pick out 4 areas we thought were worthwhile chatting about.
And I think this is a really impressive thing about the EAU guidelines is how frequently it is updated. So when you're reading these guidelines that it is based on the most up-to-date evidence. And the data and the recommendations really reflect that. Yeah,
because it's such an amount of work. I'm sure, as Derya will tell us.
You guys work really hard.
Every year. So, you've just published one and you're already starting the next year's guideline. But it's a good point you make because many other guidelines, like the AUA guidelines, they only get updated every few years and stuff moves quickly. And so that's why...
And when there is practice-changing data published, people are looking to these guidelines to see, well, is this going to make a difference? Is it going to change the recommendations? So... there's a lot of anticipation surrounding the release of these updated guidelines.
Yeah, so Derya, before we dive into the 4 hot areas that we've picked out, tell us a bit about how the Guideline Committee works. As I say, it's a huge amount of work led by Phil Cornford and yourself.
Yeah, so thank you. It's a great pleasure to be here again after being there last year. So actually, we already had our first meeting of the guidelines a few weeks ago for planning next year's guidelines. So we really start a year ahead of the EAU meeting for the update. So it's indeed a lot of work involved, and all the guideline panel members are really working hard already updating their parts of the guidelines.
Wow, it's monstrous. And I suppose, Gianluca, you have a perspective sitting on the main board with Maria Rabal, your chair. It's a massive process. I don't know how many people are involved, how many boards, how many individual guideline panels there are, associate members.
Yeah. So I think this is also a good occasion to celebrate and recognize the hard work really behind the scenes. So you may imagine, I think we are now 20 panels. So non-oncology and oncology guidelines, counting up, I think, to 350 people. So panel chairs, panel members, associates, and all the staff, office staff, and patient advocates. So it's really a big, more than a big family. So this is also, great part due to the tireless efforts put by Maria.
It's nice to get that insight because people don't realise just how big a group it is and how much work goes in behind the scenes. Derya, just quickly out of interest, is there a deadline for consideration of new data after which you close it off for the next year?
Yeah, indeed, there is a deadline. It's every year. It's a different one, but it's about end of October, November. Unless there's an abstract, for example, presented at ESMO and where we know it's coming up, the publication, then we would still wait for it and try to put it in. But otherwise, if there's a big study coming out 2 weeks before EAU, then that's too late for us. Then it's already in print. So
and it's considered for the next year.
Yep.
Very good.
Awesome. Well, yeah, look, I think it's one of the single most valuable benefits of being in the EAU, and one of the most important functions it carries out is the guidelines. But listening to what Derya and Gianluca just said, it's a reminder of the amount of work involved. I've never been invited on one of these panels, but I hugely value it. I hugely respect it. As you know, every year when we're going up to the EAU, because they get released at the EAU, don't they?
Yeah, usually while we're on
the airplane.
To the EAU.
You're checking in for your 24-hour flight and what are we going to do? Watch a movie. But for the last 3 years in a row, every time I've been getting on the airplane, the guidelines have just been published, so I've got 24 hours now. No excuses not to be up to date on it, and it's exciting at the meeting. You know, when you go to the big plenaries and speakers are putting up, and in the just updated guideline, this is what you see, and they put up the nice boxes, the recommendations, the grades of evidence, etc. So yeah, awesome, love it. But so our audience love these guidelines as well. They're very, very important, and as I say, you know, it's a 250-page document, so it's always going to be a reference thing when you're preparing a talk or you're preparing for exams. You can always go to the EAU guidelines and say, what do the EAU guidelines say about this? Because it's not just the boxes with the recommendations. The discussion before and after are like your key reference because they update that constantly.
Or you can go to GUcast and say, what did Derya and Gianluca say about this?
I know, or go to the TikTok where they talked about it. Exactly. Yeah. So there are 4 things, Derya. So what we're going to do over the next little while is talk about 4 areas that we've picked out that are interesting changes or changes in emphasis, I suppose, in the guideline, and we'll have a chat about them. So let's go through these 4 things. Let's go back over to you and take us through the first of them.
Yeah, I'm happy to do that. So quite big change, although only one table actually, but it's a big change, is in the EAU risk groups for biochemical recurrence of localized and locally advanced prostate cancer. So as it was, the definition was low risk, intermediate risk, and high risk, as you know, for a lot of years. Now the intermediate risk group has been subdivided in a favourable and unfavourable intermediate risk group, similar to the how we know it from the NCCN intermediate risk groups. And the intermediate risk unfavourable group entails ISUP grade 2 and PSA 10 to 20, or ISUP grade 3, which would be an unfavourable intermediate risk according to the now EAU risk groups from 2025.
Very nice. I really like this change because I think it's very practical. We use it, in everyday practice, and especially when we're talking about who to kind of categorize for or prioritize for PSMA PET in terms of staging. The unfavourable, intermediate, and the high-risk group are exactly the pro-PSMA criteria.
Correct.
So it is very practical, and I like that change.
Yeah, and it's important, Gianluca, isn't it? Because it's such a heterogeneous group, intermediate risk prostate cancer. And we all know, we've known for years that the bottom end of that group, the favourable end of that group, are patients who clearly don't need active treatment, at least now, imminently. So what's your take on this for clinical practice, that split into favourable and unfavourable intermediate risk?
So I personally think it is a long overdue. Of course, we know, and as you correctly said, we still practicing in this way. So we just have the confirmation from the authority of the guidelines. But of course, I think most of the centers are now splitting patients into favorable and unfavorable. And I agree that intermediate risk as a whole group is really heterogeneous, but I would say also within the two categories. So you have also the favorable intermediate risk that probably has an higher PSA or probably a bad MRI. So I think we have to probably find out new categories within this group. And I think it is important to notice, and the guidelines were correctly doing so, that these are based on systematic. So the ISO grade group on systematic biopsy. Of course, we are now living in the era of target biopsy, and of course, we would like to see probably new risk groups based also on the ISO grade group on target biopsy. We all know that is a kind of inflation of grading. Of course, we probably, and I'm a little bit surprised that probably the research in this area is kind of lagging behind, and so we will need some new risk stratification based on the results of the target biopsy. Because as you know, some people can qualify as unfavorable or even high risk on the target biopsy only. Let's think about for a guy with an ISO grade group 4, for example, only on target biopsy, and probably ending up in ISO grade group 2 of radical prostatectomy. So this would mean probably a treatment intensification with this guy, but without any good reason.
Very good.
I think splitting them is very interesting because it's still heterogeneous. So even within favourable intermediate risk, as I mentioned, I think the opportunity there is to be doing more active surveillance. We're already doing some, aren't we? But we can probably do more. And I think what the new stratification gives us is a clear box now of the favourable intermediate risks. But within that box, okay, who are the real active surveillance candidates, And that's into the finer detail of percentage pattern 4, presence of cribriform, which the guideline already talks about. What about the role of imaging to stratify these patients a bit better? Where we because we have a prospective trial, the confirmed trial recently in European Urology Oncology, looking at PSMA PET for these. So but it's very, very welcome, and it really just helps streamline your thought a bit better. So number one, we love that one, Derya, as maybe Gianluca said, a bit overdue, but seeing that beautiful table now, it's going to appear everywhere. So there's no longer any uncertainty about the fact we can draw a line down the middle of intermediate risk, and even though it's still a bit heterogeneous, there's one box and then another box.
And maybe in the future there will be an favourable intermediate risk group, active surveillance risk group, like a subgroup within, and just like you said, these points of how many calls are positive, patients can be categorised into a risk category for their risk of active surveillance.
No worries. Number 2, Derya, what else have you picked out for us?
Yeah, so number 2 is a short one, but maybe not a lot of people have recognized it because I haven't seen so many tweets about it yet. But I think it's an important change because, as you remember, in 2024, there was the highlighting of PSMA PET CT as staging tool in high-risk localized disease or locally advanced disease. But for intermediate risk disease, the guidelines table in 2024 still mentioned cross-sectional abdominopelvic imaging and a bone scan in the first paragraph for intermediate risk disease, and then only stated you can do a PSMA PET CT to increase accuracy. And this now changed in 2025 to have PSMA PET CT in the first paragraph, and there's only this paragraph remaining to have a PSMA PET CT also in this case if it's available, and obviously if it's not available to do then a CT or bone scan. So I think this again is a significant change and also fits to what we just talked about, the more granular table of EAU risk groups with unfavorable and favorable intermediate risk, where now in unfavorable intermediate risk, the guidelines also clearly highlight the use of a PSMA PET CT for staging.
Oh, we've definitely noticed it in Australia. I've already pointed it out in a couple of talks, I think, and it's great because it justifies the practice that we've had in Australia now for a few years.
Yeah, and as you said, which was based off the back of the PRO-PSMA trial, because for that trial, we included unfavourable, intermediate risk and high risk. And I remember when we were designing that trial, it was originally a high risk only trial. And I argued very strongly we should include the unfavourable intermediate risks, which wasn't a common category when we designed that trial back in 2017, 2016. But I said, this is the real sweet spot. These patients, there's a clear separation in biochemical recurrence between patients with primary pattern 4 versus more favourable intermediate risk. And it also made it easier to recruit the trial and so on, because that's a significant number of patients. But it's great to see it in guidelines all these years later. And I remember when we did a sensitivity analysis, Gianluca, on this group of patients, the ones that didn't have grade group 4 or 5, the hazard ratio still held up in favour of PSMA PET CT for accuracy. So clearly there is value here from an accuracy point of view, which was the primary endpoint of the trial. And yeah, so what's your take? What's your reaction?
So as soon as we started the PSMA, so it was I think 2 years ago, then we decided from the beginning to include also this ISO grade with group 3 patient undergoing staging. So this is of course something that other centers have decided to do. We are happy to have also the confirmation from the guidelines. Of course, I think one nice thing is that if you read the text, then the guidelines are quoting one study to kind of support this extension of the criteria, and pointing out to the potential prognostic value of the PSMA PET, quoting a prospective study where PSMA PET had also a prognostic role, improving the biochemical recurrence-free survival in the study. You maybe are aware that European Urology has recently published the PP2, this promise registry update with new mammograms, and again, the prognostic value of the PSMA PET is there. And so I think that, of course, expanding this indication for staging to that kind of category of patient now is, of course, of value as a practical consideration and implication. Of course, I think another point is the real-world data on the performance of PET PSMA. Then we know that in centers of excellence, the performance is very high. What probably we do not know yet is how it's performing in the in non-academic or non-tertiary centers, because of course, as we all know, we can also derive wrong decisions from not well performed PSMA. So that would be my word of caution. But I think data are accumulating towards these directions.
Very good.
But the reimbursement thing is still a challenge, but it helps Renu, doesn't it? We've seen it before when the major international guideline body weighs in on something with supportive evidence. It can help you get it across the line for insurance in countries or national funding. But I think as Derya nicely said earlier, when she's talking about the other risk category, we recommend PSMA PET, but if you don't have it, then you can do this. So the guideline is nimble enough to say, all right, not everyone's going to have access to this. So, but it might help. I think that's the point, is that we'll hopefully see this will improve access maybe.
And Derya, in the guidelines now, oh, sorry, Gianluca, you were about to say something.
Just that I think we as a urologists and as clinicians have to educate some nuclear medicine physicians. Because, for example, at the beginning, they were reluctant to include this lower risk category in the staging. So I think we have also to pound the word and convince with evidence our colleagues that it's the right thing to do. So to stage patients also not the highest risk profile, but also the intermediate to high risk Of course, that's a problem for the resources and so on, but it's a continuous education process within a multidisciplinary team and board.
So going forward, the recommendation to use conventional imaging, is it only if PSMA PET is not available now in unfavourable, intermediate and high-risk disease? Does it exist in any other form in these guidelines?
So for high risk, it's pretty clear you should use it. For intermediate risk, actually, when you read it, it's also that it clearly states you should use it if available to increase accuracy. So it's clearest in the high risk, but it's pretty clear also in the unfavourable intermediate. So if you have it available, there's actually no reason not to use it.
So if you have PSMA PET CT available and access to it, then there's really no role for conventional imaging now in the staging of prostate cancer.
Yeah, that's right. Yeah, active surveillance without stage.
Wow.
And the other stage.
It's been rendered obsolete by the guidelines.
So progressive.
I love it. Now, this flows very nicely, Derya, into the third topic, which is about pelvic lymph node dissection. And last year it was one of the big change. It was the big change, wasn't it?
Yes.
Yeah. The massive downgrading of emphasis on pelvic lymph node dissection for both intermediate and high risk prostate cancer. We've had whole podcasts on it. But since last year's guideline was published, there was an interesting paper published from Memorial Sloan Kettering from Karim Toujer and team, an update of the randomized trial, big randomized trial, 1,500 patient trial that they conducted comparing extended pelvic lymph node dissection with standard pelvic lymph node dissection. And so that trial has been published since then, and it fell into your window for looking at it to see whether your guideline would be updated. And we've had a very detailed discussion on this on
dedicated
GUcast.
Podcast on this.
Full podcast on it with Karim, and by the way, the trial is a negative trial. The primary endpoint was to see whether extended lymph node dissection would improve biochemical recurrence survival, and it didn't. But in the updated paper, they did have this post hoc type analysis, a lot of data dredging, as I think we described it on the podcast. And they did manage to come up with a p-value that said that there was a reduction in distant metastasis, apparently, in patients who had an extended pelvic lymph node dissection. But, lots of issues with that. MFS wasn't pre-specified in the protocol as an endpoint. There wasn't a protocol-driven imaging to be done at this point or that point or another point, or the type of imaging and so on. So lots of issues with it. So we were all very interested to see, would the updated guideline take into account this paper and change your recommendation on pelvic lymph node dissection? Over to you.
Yeah, so thank you. Indeed, in 2024, when this big change of the recommendations with regards to lymphadenectomy came, there were lots of discussions. And actually, when we talked last year on this podcast, we already had seen the abstract at the game-changing session in EAU. But we don't include studies if they are not published, peer-reviewed and published. So this was not included anyway but in the 25 now we had the full paper. And fortunately, we were also invited to write the editorial for this paper in European Urology. And there we really outline why this paper has not led to a change of the recommendations in 2024. And I would like to just highlight a few points out of this editorial for the listeners of this podcast. For example, the primary outcome was not really clearly defined in the publication. Overall metastases were listed, then it was said distant, then regional metastases were stated to be separate, and also these endpoints were not really outlined within the prior publication or in the clinicaltrials.gov registry. That was one point. The other point you touched upon was that the imaging modality used to identify distant metastasis was not clear in the manuscript and was also different between the arms. Also, post-operative management choices, which we know do significantly impact the oncological outcomes, were different and not pre-specified, as the endpoint, the primary endpoint was BCR. And one of the really important points is the randomization structure, which was pragmatically changed from an initial 1-to-1 to a cluster design to 3-month blocks. And this design is known to be at increased risk of bias. And also awareness of the allocation within these 3-month blocks could allow surgeons to selectively enroll patients in the trial. So therefore, we concluded that although this trial, of course, is important to demonstrate how large surgical trials can be completed, and we really also in the editorial commended the authors and patients on completion of the trial and the providing information for consideration by clinicians. But due to the uncertainties we mentioned in the editorial, we didn't think that the study can be considered as practice changing. And this is especially in an era of PSMA PET staging before surgery, which has the potential to significantly alter the risk profile of patients undergoing pelvic lymph node dissection. And having said that, within this 1 year, we have written really a handful of editorials also to explain this, because a lot of urologists have asked for an explanation because they didn't understand why our recommendation changed. And we also wrote an editorial only about that, so a separate one from the one which was for the paper by Dr. Tugier. And a few highlights from that are that really the change of recommendation in 2024 was in part driven by the decision to recommend PSMA PET for staging, because its ability to identify additional lymph nodes deposits beyond conventional imaging, as we just talked about, reduces really the gap between imaging and pathological staging to fundamentally alter the risk-benefit ratio of performing a lymphadenectomy. And just at last, a third editorial, which we wrote within the guideline panel. So this is also guideline panel work I want to highlight, is not only that we update the actual guidelines, but we also write a lot of commentaries, editorials, and systematic reviews to also explain the recommendation. And this third editorial was an editorial on the use of PSMA PET CT for nodal staging and prostate cancer and tailoring of treatment. And I just want to highlight one really nice quote of this editorial, which I find really important. And I don't think everybody thinks about this, but it's important. It states, pelvic lymph node dissection has the inherent drawback of yielding a pathological result for end stage after the prostate has already been removed, so it cannot inform the choice of primary treatment. And therefore, I believe it's really important to, from now on, also to think about alternatives than only the option of lymphadenectomy for lymph node positive disease even, or identification of micrometastatic lymph nodes.
Excellent. Wow. What a masterful overview of the guideline work.
And it just shows how busy you've been around this one recommendation.
Yeah, and as Derya says, they write these to help explain how they reach a conclusion, because it's one thing to publish something or people only look at the recommendation box. How did you do that? And like months of
why?
work and all the panel that goes into it. So yeah, but it remains as ever, pelvic lymph node dissection, prostate cancer, a contentious topic, will be, ad infinitum, I think. But I do like the clarity that the guideline committee have put across this. And I think it's perfectly reasonable, isn't it? I mean, this is a non-practice changing trial. It's a negative trial, didn't improve biochemical recurrence. Like, take out 2 extra lymph nodes, no surprise, takes 2 minutes longer, you don't improve biochemical recurrence. And to make that leap to say, however, distant metastases will be improved, makes no clinical sense whatsoever. And I think my conclusion on the previous podcast that this is just statistical shenanigans is borne out in my view, that this is just found by, excessive data dredging, p-hacking, it's also called in the industry, and they finally reach a p-value that's that's significant according to them, but it makes no clinical sense, and therefore it's not practice changing. So, but thank you for the explanation.
Yeah, I have one more important point before maybe Gianluca can comment. Also, these comparisons are also, I don't think, up to date anymore to compare extended versus limited or no lymphadenectomy versus lymphadenectomy and then decide about an endpoint. I think the main question is that it is unclear whether extended pelvic lymph node dissection first with subsequent adjuvant or salvage approach, or no extended pelvic lymph node dissection with PSA or image-guided post-operative treatment is superior in terms of oncological outcomes. So meaning there was a really interesting study from Australia, from Yaxley and colleagues. They looked at how many patients have to receive a lymphadenectomy that we can have one patient who's free of biochemical recurrence for a long median follow-up. And they found it has to be 400 to have one patient long-term free of recurrence. And why should one do it if we could treat those which really then, after the prostatectomy has been done, recur, and where we know, okay, they have a positive lymph node, and then we can treat it. So I think in the future, studies should look at this comparison to do one group with lymphadenectomy and the other group with really targeted care, where you look at PSA, PSMA PET, CT at biochemical recurrence, and then treat these patients.
Yeah, I mean, that number needed to treat really puts a lot of things into perspective. So that's a really important point that Derya's made. Gianluca, what are your thoughts?
Yeah, so I agree with the Derya proposal. So the ideal RCT now is one arm, no lymphadenectomy, and then act in case of PSA or clinical progression. The other arm is doing an extended lymphadenectomy, of course, if we still believe in that. And then, of course, the third will be a salvage, so an immediate salvage pelvic treatment, let's say, whether SBRT or elective nodal radiation. The PIS5 storm has been published, I think, today. So the elective nodal is better than the targeted SBRT. So that of course is the ideal RCT. Probably we will never see that study, but of course there are, for example, some RCTs where the decision to proceed on lymphadenectomy is based on the PSMA staging. So-called PSMA triage trials. There's, I think, 2 in the Netherlands, in Amsterdam one, and the other is the national Dutch. And so then in case the PSMA is positive, so you have an MI N1, then you go for lymphadenectomy. And if you have a MI N0, then you randomize between no versus extended pelvic lymphadenectomy. So I think we will have some data, but I think what we see in practice, I have to say, is fewer and fewer surgeons believing and doing a properly done PLND. So I think a PLND is going into the direction of conventional imaging, so towards obsolescence. So this is what we see. I think I started in the 90s, you remember. So that was the eminence-based practice to do extended PLND. You know, every patient going to the table deserves a PLND for his prostate cancer. So PLND for everybody, minimum 20 nodes. So you remember, so push to the Einderreich, the San Raffaele group. And now I think we are shifting to really fewer and fewer cases where surgeons are thinking that they are doing a good act in performing a PLND. And I think this was, I don't know, probably before the explosion of the PSMA staging. Probably it is something to do with the robotic surgery method. Probably the first wave, but the second and third wave. So people were more concentrated on other things during their surgical intervention. And honestly, probably no detriment to the survival of the patient overall.
I mean, I think you're right. I think the ideal RCT in this space would be no node dissection versus an extended node dissection in a PSMA PET triage population. But I think the ship has sailed in many countries when it comes to a lymph node dissection in the PSMA PET era.
In patients with a negative scan, certainly has in Australia. But yeah, look, and I think the EAU guidelines are certainly contributing to that change that you see in clinical practice, Gianluca. I think that because people look towards the guidelines, and there was a lot of talk after last year's meeting. It still comes up all the time in meetings, and people putting up the table and the graph, and we've talked about it a lot on this podcast. So, I think it's a lovely bit of work. And so in summary, point number 3, no change to the 2024 recommendation, and that is taking into account the Memorial Sloan Kettering trial. And we'll have to wait till the other trials come. Yeah. And of course, there is a big Martini-Klinik trial, Derya, in this setting as well, of pelvic lymph node dissection versus no pelvic lymph node dissection. Huge trial, 2,000 or 3,000 patients. Can you tell us what's up with that trial?
Yeah, it's finished recruitment. But this trial, the caveat is that it is only in intermediate risk patients. Yeah. So unfortunately, there are no high risk patients in it, where I think the question is even more important.
And again, not driven by PET imaging in all patients, etc. But yeah, very good.
Yeah.
Okay, that was a big one. Brief one to finish then. Renu, mHSPC. I mean, a lot of changes in mHSPC, and it's important that us urologists know about these changes in practice. But Derya, you wanted to draw attention to just one slight change. I mean, this section of the guidelines is changing every year because of RPs, etc. But you want to draw attention to one of the changes, I think.
Yeah, so there's a new recommendation on use of darolutamide. Now it's included as a doublet of darolutamide plus ADT to patients with M1 disease who are fit for the regimen. And this recommendation was based on the ARANOTE study, which included patients with metastatic hormone-sensitive prostate cancer and randomized them to darolutamide plus ADT versus placebo plus ADT, and the primary endpoint was radiographic progression-free survival. And what was seen was that darolutamide significantly reduced the risk of radiological progression or death by 46%. And that's the reason why it's now included in the guidelines.
I think that's a reassuring thing. So ARANOTE, of course, was read out at ESMO last year, and there were a few concerns regarding, the hazard ratio for the radiographic progression-free survival, and also the lack of OS that was seen with the other RPs. But the fact that it is included in these guidelines, side by side with the other agents is good for clinicians to know.
Yeah, and longer follow-up will deal with that, I suppose. And but I suppose it's a great resource to go to EAU guidelines because it goes through all of the options for mHSPC. They've added darolutamide in on top of what already is in there, enzalutamide, apalutamide, abiraterone, etc. And so I think the overarching recommendation is that, if you're starting your patient on ADT for metastatic prostate cancer, you need to be intensifying that for the vast majority of patients. They should be intensified with an ARPI. And this year, darolutamide now gets added in as one of the options for intensifying with an ARPI. And Gianluca, finally, to finish on that, there were some other subtle recommendations about the whole approach to mHSPC as well, I think.
So I have to say I appreciated a lot the new recommendation to discuss all patients with a newly diagnosed hormone-sensitive prostate cancer in a multidisciplinary team. I think this is, of course, a very important recommendation, really, really important. There is no specific evidence to substantiate this recommendation if you read the text, but probably it doesn't mean because it is, clinical common sense. So, and I think the value of multidisciplinarity is undeniable. So it's a win-win for all the stakeholders, in premise patients. And of course, this I think it is important because we know that the treatment intensification is in many countries not pursued. Not even proposed. So many patients are treated with ADT, probably by the referring urologist, in this private office, because it's a tradition to do so. But of course, there are so many options and strategies to push that it couldn't be possible to manage this patient any longer as a single urologist. The patient may profit from treatment intensification. It might be possible also to discuss treatment de-escalation. So you may imagine a guy who is put on ADT and probably he would have needed a treatment intensification and probably he would have benefited from a treatment interruption or suspension 1 or 2 years later. So there are many reasons to make this recommendation really important.
Excellent. There you go.
That's great.
4 hot topics.
Yep. Splitting of the risk categories, important change. And it's lovely to see that it's had this sort of ripple effect throughout the rest of the guidelines. That is the recommendation of PSMA PET in the unfavourable intermediate risk staging group. And again, a ripple effect from that. No change to the recommendations for pelvic lymph node dissection in light of PSMA PET staging. The recommendations for doublet therapy in mHSPC, pointing out that ADT alone is no longer the standard of care in these patients.
And good to know they're already back at work getting ready for next year's guideline update. No rest, Derya, and an amazing process. So, well, look, congratulations to you and the committee, Phil, and everyone who works under the EAU board, Maria and Gianluca, and everyone who's on that board, and the dissemination committee. And we like to do our bit to draw some attention to these guidelines.
Yeah. And remember, these are just the prostate cancer guidelines.
Yes.
And you just mentioned Maria Rapal, who runs the bladder cancer guidelines committee, and the guidelines are amazing. So if you're ever in doubt, please have a read.
Exactly. Okay, so look, that's all we have time for on this episode of GUcast. Thanks so much to you, Derya and Gianluca, for joining us. It's been a great to have this update again. It's now an annual event having these two on to talk about the prostate cancer guidelines.
Right. So same time next year?
Yeah.
Right.
Maybe a little earlier.
It's very late in the evening in Europe, so thanks very much to them for staying up to us. And that's all we have time for on this episode of GUcast. Renu, we'll be back again soon with plenty more.